speak to all you guys today. I'm going to introduce our guest speaker right now, Dr. Steve Diana. I've known Steve as a friend, as a colleague for the past 27 years, a long time. And Steve, myself, and Dr. Jeff Sumner have been classmates from 1997 from University of Toronto. So Stephen has private practice in Georgetown since 1999, and he's built a training facility at his location ever since. He spent a lot of hours learning about implant dentistry in Canada, the States, and Europe. And he teaches comprehensive restorative and surgical implant training. And actually all my associates, all Dr. Sumner's associates and all of Dr. Hisham Shergan's associates have recently attended all of his restorative and surgical courses. At his learning center is called Peer-to-Peer. So for those of you who haven't seen it, go check it out. Steve also speaks at a national level, and this is probably his first time speaking nationally in front of his computer. So Steve, take it away.
Thank you.
And just before Steve gets started, I just wanted to also remind everyone to please go ahead and type their questions into the chat area, and we will address those, or as many of those as we can at the end. Go ahead, Steve.
All right, thanks. So I'm going to need a little bit of help with this. I'm going to just let me know if I've got this up and running properly. Can you see my screen?
Yep, we can see it now.
Is it proper now?
Yep, it's perfect. You are good to go.
So give me a little help if I end up getting off key here. And as Mian said, it's first time speaking into a computer, so it's a little bit new for me, so bear with me. Thanks for the introduction and thanks for the invitation. First and foremost, I appreciate the opportunity to come out and speak to everybody. So far, the lecture series has been incredible. I was really excited to see Steve's lecture and Azim's lecture about implant dentistry, and it made me kind of reshape my lecture for today to try and make things a little relevant on a general practitioner level. It's really exciting to see colleagues, because we all practice in our own little bubble. We come to work, we do our thing, we go home, we know what we do, but unless we interact with each other, we don't really know what everyone else is doing out there. And so when you can see colleagues that you aren't aware of doing some pretty incredible things, it's pretty refreshing. So my interest has always been in implant dentistry, and that's what I focused on for the last 22 years of my practice. And I know what I do, and so it's really, really exciting to see some pretty incredible stuff being done by colleagues and sharing that with each other. So I appreciate the lectures, and hopefully I can kind of add into the equation some of the things that were to make the whole picture complete. So my perspective with respect to implant dentistry, I think it's a very unique part of dentistry in the sense that it involves surgery and it involves restorative. And sometimes there's a discontinuity between the two, where GPs are very restoratively driven. They will send out to a surgeon and the surgeon or periodontist, and that person will do the surgery. It comes back to the restorative doctor, who then restores the case. But maybe the surgical person doesn't ever see the final restorative result. So blending those two disciplines together and offering the whole treatment in one center, I think it gives you a unique perspective to kind of really see where we can accomplish what we can accomplish, whether it's surgical or whether it's restorative. So maybe some of the things that I'll enlighten people on today or make you think about will be helpful for a surgical person who's never seen the restorative case, or from a person who's only restorative, so that they can understand what can be accomplished from a surgical point of view, so that we can end up with some nice results. Before we get there, I'm going to give you my little COVID story. These are my three kids. I've got 17 going on 18-year-old son, Ethan, on the left, who's just got into biomedical engineering at Mac, and so we're pretty proud of that. Christian is my middle son, who's 14, and he's on Team Canada for acrobatic gymnastics. He's supposed to be in Belgium last week for a competition which got canceled because of the COVID, and he's supposed to be in Geneva in May for Worlds. So my COVID crisis right now has been watching my son, who trains 25 hours a week, not be able to go and do his passion. He lost his platform and he's not going to get it back, and that's kind of a little heartbreaking for me. And my daughter Jordan just had her 13th birthday at home with no friends. She had a Zoom birthday party, kind of like this. So those are my three kids, and that's kind of a little picture about what Christian does, which I think is pretty exciting. So acrobatic gymnastics is something that we don't see a whole lot in Canada, and the platform is more of a European platform, and it's pretty incredible stuff to see what these young people can do. That's him up in the air. So we're kind of sad about the fact that right now he should be doing his thing that he's worked so hard for, and he kind of lost that little platform, and hopefully he kind of gets through this little bit of a depression that he's in right now and gets back to training in the next, who knows when. Just like us, we don't know when we're getting back to work, so he's waiting to get back to the gym. So with respect to our talk today, I really enjoyed Azim's concept yesterday, or sorry, the other day, with respect to having a plan. I think that was a really crucial part to that whole lecture, where it was emphasized that doing something works out well if we have a plan in place and if we stick to that plan. And I really respect the fact that Azim mentioned that despite the fact that we do something as much as we've done it, sometimes the more confident we get with something, we start getting a little complacent and we skip steps. And when we skip steps, we make mistakes. So having a plan and sticking to that plan is really the only way to come up with predictable results repeatedly. So I'm not going to try and teach you today how to accomplish the ultimate aesthetic result with implant dentistry. I want you to be able to look at cases and start to come up with an understanding of each and every case that you approach, and be able to anticipate what the final result is before we actually even start the process. So again, if you're not doing your surgery and you're deferring your surgery to somebody else, you still need to understand what could be accomplished surgically. And if you're not doing the restorative, you need to understand what could be accomplished from a restorative point of view. And it's the blending of those two things together that makes the case work out really well. So when we look at a case like this, it may not be perfect, but was it predictable that I would be incorporating pink porcelain into this case prior to even starting? So should we be able to understand that this is what the case will look like before we even start talking about implant dentistry and grafting and how many implants and where do they go? What is the case going to look like before we start? So again, predictable. How do we incorporate this plan that Azim laid out for us, but with a predictable outcome? And this is exactly why the college has outlined the fact that we, as implant dentists, need to have both surgical and restorative training. You can't just have one or the other because they're so dependent upon each other. And it says, sorry, let me just minimize my grid here. I don't think I need to look at myself. It says here that all stages of implant dentistry are driven by the goal of achieving the end result, the definitive final prosthetic. Careful patient evaluation and treatment planning, followed by meticulous execution of treatment steps, are necessary to achieve the desired outcome. In other words, it's the end result that matters. If you don't accomplish what the patient wants, then you failed, according to the college. And I think that's fair. So we need to understand what the patient wants, and we need to understand if what they want is achievable. It doesn't mean just because they want it that we have to provide it. It may not be something that can be accomplished, but it's your job to be able to understand that by diagnosing the case and treatment planning the case, what is the predictable outcome going to be? So this ultimately is what we're looking at. We're looking at both white and pink aesthetics to come up with a nice result for the patient. This is an immediate extraction, implant, abutment, same-day crown. And this is the kind of result that patients are looking for. So how can we predict that this is the kind of thing that we can achieve? We need to have some parameters and some basic guidelines to look at. Everyone's with me? My audio is okay? Slides are good?
Doing great, Steve.
All right. So what do we treat with implant dentistry? So we treat, basically we'll go through the continuum from basically a single tooth, multiple missing teeth, so bridges, full edentulous arches that are fixed, and full edentulous arches that are removable. And we need to kind of look at these cases individually and be able to identify some parameters that we can outline to know as a checklist, kind of like Azim's plan, some things that we should be looking for to know what the result's going to look like before we're finished. So you'll see on this patient, she has a single central, a 1-1. She wasn't happy with it. Young patient, had endo. That's the second crown that we did for her. She wasn't happy with the graying of the tooth. The tooth underneath was black. It had a cast post in it. God knows why. She just wasn't happy with the gray that was showing through the tooth, and she wanted to extract it in an implant. We extracted the tooth. We did the same-day implant, same-day temporary crown, and then transitioned it into a final crown, and resulted with a result like that she was pretty happy with. And to me, that's a successful result. Now, I'm very proud of that result, and I'm not going to show you all the cases that I'm proud of. I'm going to show you cases that I'm not proud of, because those are the ones that you learn from. But when you look at a case like this, what really defines this to be an acceptable, successful result? Well, there's a few parameters that we look at to make this for a single tooth to be successful. We have symmetry of the zenith of the adjacent teeth. We have symmetry of contact points and papillas. We have nice ceramics done by the lab, and that's my biggest crutch these days, is really getting consistency of the lab work. It's hard to hand something off to somebody else and lose control of a case, but we do that all the time when we end up taking impressions and sending things off to labs. And we have a nice emergence profile. So we have a good, robust, stippled, healthy, keratinized tissues that surrounds that crown that tends to be symmetrical with the adjacent tooth. So getting success in a single implant, single tooth case, to me, those are the things that I'm looking for. The zenith, the papillas, the ceramics, and then the emergence profile. When I have multiple missing teeth, and we're talking about a bridge, if our tissue volumes are adequate, so if we have adequate bone and soft tissue, then we can usually accomplish a pretty aesthetic result as well. Now, if we have deficiencies in those tissues, whether they're bone or soft tissue or both, we need to identify those in advance to understand what kind of aesthetics we're going to result in. If we're talking about a fixed case that's a full arch, the bigger the case gets and the more the teeth that are missing, the more likely that we're going to have some tissue loss, whether it's bone or soft tissue or both. So in my experience and in my years of practice, the majority of my fixed arch cases tend to look more like this. The teeth look longer, the contact points are longer. We don't have as nice papillae as we do around implants next to adjacent teeth. So we have a compromised aesthetic result because there has been tissue loss. And by virtue of losing your teeth, unless you've extracted all of their teeth for for caries reasons, let's say. So if there's been a complete loss of teeth for caries, then that's, in my opinion, one of the few situations where you're going to be in a situation where you have the most abundant amount of tissue to work with to get the most aesthetic final result. For the most part, the patients have lost some kind of tissue, again, whether it's bone or whether it's soft tissue. So we have smaller papillae and longer contact points. If there's been buccal lingual loss of bone, then we end up having a little bit of ridge lap, which is what? It's a compromised emergence profile. And is that an issue? It's not your position to decide for a patient if that's an issue or not. It's your position to diagnose it in advance of doing it and giving the patient an understanding of what the outcome is going to look like. So again, that we're trying to achieve predictability. So if I diagnose a case and in advance, I can know that there's going to be some ridge lapping of the bridge. Just because their lip line hides it doesn't mean it's acceptable. It may not be acceptable to them, and you need to let them know that in advance so they can decide whether or not that's going to be an appropriate outcome for them. When we talk about patients that are completely edentulous and we're doing a removable prosthetic, by default of going into a denture, the patient has kind of accepted the fact that they're going to have pink and white aesthetics. So we're not worried about embrasures and soft tissue profiles as much. But what we need to do with these cases is we need to ensure that when we place these implants for these cases, is that we've provided adequate prosthetic room to provide the nice aesthetics of the acrylic and whatever components you're going to use to connect the implants to the prosthetic. And that's the biggest thing that I see with more novice implant dentists is not doing adequate reduction of tissue to accommodate the prosthetic requirements that are required for a removable denture. So I noticed yesterday in Kayvon's lecture, which was fantastic, by the way, it was an incredible talk about orthognathic surgery, and Sham and I talked briefly this morning. We're really kind of both on the same page, being impressed with the amount of digital understanding and digital treatment planning that the surgeons are incorporating into their cases as well. So it's really an exciting thing to see. But Kayvon's lecture, and I think even Azim's lecture, we all incorporate these slides with a puzzle. And it's because it's exactly what we're doing. When we look at a patient, it's a puzzle, and we got to put the puzzle back together. And at the end of the day, the more complete the puzzle is, it's easy to see where that last piece goes. But you deconstruct that puzzle, and all of a sudden it's a lot more work, and you have to figure things out. So the simplest thing to do to try and figure out how to put things together, like Azim had mentioned about a plan, was it all comes down to accumulating your records. Now, it's not all about accumulating records. It's about understanding your records. If you don't understand, there's no point in giving me records if you don't understand what you're looking at. And when we do our mentorship and our training program here, I see this time and time again from some dentists that will just give me a beautiful presentation on gathering all the records, which quite frankly, their auxiliaries probably did, but they don't understand what they're looking at. So I need to kind of help direct people towards some key parameters, what they need to look for. So we need a good medical history. We need good photos. That was mentioned yesterday as well. It was mentioned in every lecture, this concept of photography. I've been using photography for the last 23 years. To me, it's invaluable. Study models, radiographs. I'm becoming more digital. We just incorporated a cone beam into the office. We've had an Omnicam for quite some time. We just got the prime scan. So I'm getting more into the digital side here, but I've been more of a bread and butter, photos, models, panoramics, PA, and study models, and more of an analog dentist than a digital dentist. But the digital dentistry age is here, and we need to be on board with it. If you're not on board with it, you're missing the boat. Surgical guides are not, to me, again, I tend to incorporate surgical guides more into more comprehensive cases. I don't use them so much for single tooth cases because, again, going back to that concept of a puzzle, when I've got a lot of pieces that are giving me direction, I don't feel like I need to guide quite as much. But again, I think that comes down to experience. So medical history, photos, study models, and radiography to me are part of every single case. And whether or not you incorporate cone beam and surgical guides is your decision. But if you look at what a basic study model will show you is, this is a case where what you're looking at is the patient's wearing their denture for the 4 front teeth. We sent them off to the oral surgeon. This was a case that I didn't do. He needed bilateral sinus lifts and he needed block grafting in the front. And in my opinion, even though I do those procedures in my office, I have access to an amazing surgeon who can take that patient to the OR. And in Ontario anyway, that grafting then gets covered by OHIP. And I give that case to the surgeon when it's a bigger reconstruction. Now, there was a little lack of communication in the case, and partly my fault, partly the patient's fault, partly the surgeon's fault. We all just were not on the same page with it. And the patient's primary concern was this reverse smile. So he really, really, really wanted to have this denture gone with implants, but he wasn't really wanting any incorporation of pink into the prosthetic at all. So he went to the operating room, he had his bilateral sinus lifts done, he had his block grafting done, and the surgeon actually accomplished an incredible graft of thickness in the anterior, but didn't get the vertical correction done. And anybody that does grafting knows that that's our biggest nemesis, is getting vertical augmentation. So at the end of the first round of grafting, the patient's looking at their prosthetic, and the prosthetic is actually telling you that you don't actually have your soft tissue in the right position to give you the teeth that you need, because the pink on the acrylic is showing you that there's something missing. So if I do a wax up and I fill it in, I can quickly take that wax up there and I can make an Essex retainer out of it, fill it with ProTemp, seat it in the patient's mouth, and so show the patient what the teeth are going to look like. And once again, as I said from the beginning, you're going to end up with long teeth, long contact points. And the patient has to decide whether they're going to accept that or not. And in this case, the patient actually didn't accept it. So they went back to the surgeon, and the surgeon did another advanced procedure where he actually sectioned the anterior maxilla and slid it vertically with fixation plates to drop the vertical portion of the maxilla to reduce that reverse curve. So again, the point of me telling you this is to show you that we can actually know in advance diagnostically what we're going to achieve before we do it for the predictability factor. It's not a matter of just sending the patient out, getting good bone, firing implants in, and then making it look as good as it can. You need to know what things are going to look like before you start. Now, careful with software. So this is just an image that another doctor sent me where they did a scan on a patient. And what you're looking at is the yellow is where the computer kind of filled in the missing teeth. So in this case, you're missing a fair number of teeth. So 1, 2, 3, 4, 5, 6, 7 teeth were filled in. And so the computer stitched in the missing spot. But when I asked her to give me a second scan with the patient's prosthetic in place, the pink shows you where the prosthetic actually is that the patient likes. So if this doctor had actually used the virtual planning of the teeth, as opposed to a more comprehensive wax up, if you will, then the implants would have been in the wrong position. So you got to be careful when you're asking a computer or anything else to fill in the blanks without all the information. You need all the information. Now, why did this happen? This happened probably because the computer filled it in with no references, no opposing. So you need to have as much information as possible in order to fill in the blanks. And the more that's missing, the more you need. So for a single tooth, if we look at it, this is the situation where the puzzle is almost complete. Your brain can look at this case, hopefully, and you can actually look at it and instantly look at it and say, okay, you know what? There's probably good probability that there would be a papilla here that's pretty good. There's a good papilla on the mesial, the lateral that would be good. The soft tissue volume looks pretty decent. There might be a bit of a crestal dehiscence here, but this overall looks like a very favorable case. You might want to cone beam it just to confirm your bone levels, but for the most part, looking at it, it's not that hard to put that one piece in and know that that's going to be a pretty good outcome. Regardless, if you don't want to skip steps, like Azim said, the minute you skip a step, you'll sometimes make a mistake. In my opinion, this is still for someone who's on the beginning of the learning curve, is to take this case and get it waxed up and try it and see where all those parameters are going to lay out. Where is the zenith going to be? What's the tooth going to look like? Now, when we have no teeth and we have a completely edentulous patient, how can your brain fill in anything like vertical dimension? Are there tissue deficiencies from a buccolingual perspective? What are the spatial relations of the teeth going to be? You don't know. So you got to work the case up. So it seems a little bit obvious, but my point is get into a routine of just doing a plan. So on a case like this where they're edentulous, the proper way to work that case up is photos, study models, and then wax it up. So you got to go through the diagnostics first. You got to get that patient to the point that you have a full occlusal rim with a tooth set up. So you work backwards from that result, and then you place the implants, and then you'll actually know what your final result is going to look like. It'll give you guidance as far as what kind of reduction you need, if any, for the ridge. So you'll get all the information by working the case up. And again, if you look at the single central, you think your brain fills it all in and you'll know, but occasionally you'll miss something, you'll make a mistake. So diagnose it right from the beginning by going through the same routine all the time. Photos, study models, and fill in the blanks. So ultimately our implant restorations end up successful if the implant's in the right position. So where does the implant belong? So for a single missing tooth, we have to talk about mesial, distal, buccal, lingual, and apical coronal. So from a mesial distal perspective, the implant should be 2 millimeters from the adjacent tooth. I don't like them any closer. When you get a little closer, we're going to talk about the consequence of what happens when you do get too close to adjacent teeth. Apical coronally, it should be 3 to 4 millimeters from the CEJ of the future restoration. And then buccolingually, the implant should come through the central groove of a posterior tooth and should come through the cingulum of an anterior tooth. So let's look at what are possibilities. This is an ideal position to me. So this is an immediate implant. You can look at the implant coming through the cingulum of the proposed tooth. I've got lots of space between the implant and the buccal plate. I'm going to graft that into place. And if you can imagine, can you guys see my cursor?
Yes, we can.
Can? Okay, perfect. So if you can imagine, what will happen is there was a time in life where we used to think that we'd have to fill that whole socket with implant, and we'd have a tapered implant and we would obliterate that socket with implant. But now we appreciate the fact that if we let that all fill in with bone, that bone is going to mechanically handle the load of that implant over time to give us good stability. But in addition to that, imagine this facial tissue rolling over towards the palatal. It's going to give us an abundance of soft tissue, which will help us with our aesthetics when we go to do that final crown. So that to me is the proper spatial relationship of an implant from a buccolingual perspective and from a mesial distal perspective. And from the photo, you can't tell the apical coronal perspective. But that to me is an ideal position. Now, what happens when we place implants too buccal? If they go too buccal, then we end up with zeniths being in the wrong position. So anybody that does ortho knows that if you push a tooth buccally, the tissue will recede, and if you pull the tooth lingually, it might migrate up coronally on the tooth. Same thing with implants. If things are too buccal, you end up with a problem with zenith. If things are too palatal, well, now we're going to end up having, you talk two things. We can talk aesthetics, where we're going to have too much tissue and we're going to have an over-contoured crown. And now you can talk about the issue of whether or not you have a non-axial loading and whether or not that's a real huge issue in a single tooth restoration. It's a relative conversation to depend on how palatal and how off angle you're talking. But in my opinion, having a single implant in this kind of a scenario is not so off angle that the mechanical issues are going to be a problem. If the implant is too coronal, we end up with a short crown. So if the shoulder is not deep enough, and Steve had made a comment about that, and he actually surveyed in his lecture about who takes that vertical measurement. And I think, again, going into what I said at the beginning about the fact that we've got some people on here that are surgical, some people that are restorative, and some that do it all. It's the ones I think that do it all that see the consequence of some of these positional errors, that start to learn from them, and then we start to pick up on those little things. But when are you going to see a situation where you're going to place the implant too coronal? You're going to say, well, that doesn't normally happen. The answer is it does happen on occasion, and most commonly it happens on congenitally missing laterals. So when our orthodontist colleagues go ahead and take a cuspid that used to be up against the central and move it and open up the space for us, it actually creates an amazing bridge of bone that often results in the shoulder of the implant being a little bit too coronal. I'm going to show you how to go through a diagnosis process so you don't forget that. And look at this one. I did this one years ago. This is like 21 years old, this implant. But look, when do you ever see this, where the crest of bone on a molar is actually too high relative to the adjacent teeth? So you think it's great, you open it up as a novice, you make a hole, you fire a big giant implant in, but where the shoulder of that implant is terrible, that results in this tiny little squat crown. It's not the right result. This tooth actually required a little bit of reduction of bone, so the shoulder of the implant would result in a nice emergence profile. And that's what Steve had mentioned in his lecture about taking that vertical measurement. If the implant is too apical, now that's more common. So if there's been vertical bone loss and the implant ends up too apical, you're going to result in one of two problems. If you don't have a good thick amount of soft tissue, you're going to have a zenith that's in the wrong position. Now, can we surgically correct that? That's our biggest challenge, is trying to correct that vertical position of bone. So sometimes we surgically just can't fix that. So it's not achievable. So now it's going to have to be fixed on the restorative side. So now we have to ask our lab to become a little bit better with their ceramics, maybe make this look like a root, like this adjacent tooth does. So yeah, I mean, all these teeth are ugly. So he's got one more ugly tooth in there. But the point is, knowing that that shoulder was going to end up where it was going to end up because of where the vertical bone was. If the implant is too mesial or distal, now, if it's too distal from the adjacent tooth, you end up with an off central. That access for that screw retainer restoration should be right in the center. It's a little too far to the distal, so you're going to have a poorly contoured emergence profile on the mesial of that crown. May or may not be a hygiene issue. Really isn't an aesthetic issue, but it's just not ideal. Now, if you end up too mesial or distal and approach the adjacent tooth too much, you end up with a disaster. And this is my disaster. And this is part of the reason why I eventually switched over to Astra from ankylose implants. I love ankylose implants, by the way. And the problem is they only had a 3.5. So in a small space like this, a 3.5 wasn't the appropriate implant to place. My error. I think the position was decent. I don't think it was perfect, but it's too close to that central incisor. And look at where this papilla should be. Look at the papilla between the 1-1 and the 1-2, and look where the papilla is between the 2-1 and the 2-2. I killed it, and that's my fault. So that's the big consequence of placing an implant too mesial or too distal. So when we look at our single tooth implant cases, and I'm going to talk fast because I know after about an hour I started to tap out on these talks a little bit. So I'm going to try and get a lot in the next half an hour. When I look at single tooth implant cases, I'm looking at, is there going to be a papilla? And that's going to be dependent on the interdental height of bone, which we're going to talk about. I look at where's the zenith of the crown going to be, and that's going to be primarily influenced by the buccal position of the implant, in addition to where the crest of the bone height is. And then I look at the soft tissue profile for its abundance and the amount of keratinized tissue I have to give me that emergence profile that I was talking about. So when we look at predictability for papilla, the biggest predicting factor has to do with the bone level on the adjacent tooth. So if you're putting an implant in between two adjacent teeth, you want to assess where is that interdental height of bone on the adjacent tooth. And Tarnow and Salama's studies showed that on average, the papilla between an implant and a tooth was about 4.5 millimeters in height. So I just need to move this out of the way. So from our interdental height of bone on the adjacent tooth to the contact point, on average is about 4.5 millimeters. So it has nothing to do with the implant itself. It has to do with the tooth. So on the previous slide where I showed you that the papilla got blown out is because I put the implant too close to the tooth and I caused some necrosis of the bone on the adjacent tooth. And that's what took the papilla out. So the interdental height of bone is one of the parameters I want you all looking at. So you look at a case like this. Here's a lower incisor with a big chronic periapical lesion. The tooth is extracted and you think, now again, different speakers will give you their opinions and their experience level will tell you that some people, I know Azim was talking about how he does mostly immediates, he may or may not approach that with an implant today. In my practice, I wouldn't. I would want to graft that first and I would come back in and do the implant secondarily. My point of showing you the slide is if you look at clinically where the interdental height of bone is, it's actually not too bad. And that's what's going to result in this. So we have a case where it ends up pretty decent when it looks clinically pretty disastrous. Like you may not be able to even get any kind of aesthetic outcome. But the papillas that we have here were dictated by the interdental height of bone that we see on the radiograph and we saw clinically. When you start looking at interdental height of bone, you start removing teeth, look at things like root proximity. There's an implant on the 1-1, patient lost the 2-1 crown post, tooth is non-restorable, is going to have the tooth removed. You look at the proximity of these two teeth. So that little bit of bone there, yes, if the patient has papilla to begin with, when I take that tooth out, may I lose a little bit of bone here? I might. So I have to tell that patient in advance that just looking at that there's a good possibility of losing 1 millimeter or 2 of bone here, and we might have a problem with the papilla after that tooth is removed on the final restoration. So there's the final implant. We've moved the implant away from the adjacent tooth for a nicer emergence. And watch what happens. So here's the implant on the 1-1. There's a crown on the 2-1. The tooth is removed. He has a papilla. I extract the tooth, I place the implant, and what happens? The papilla got lost. And quite frankly, I predicted that by looking at that film pre-treatment, looking at that root proximity, and being able to anticipate that he has a risk of losing 1 millimeter or so of bone and maybe losing some papilla. Is that an issue for your patient? I don't know. But it's better to be able to tell them in advance what to expect as opposed to telling them in hindsight, well, this is just the way it is. So that's the theme I'm trying to get. Like I think Azim's theme was all about having a plan and implementing a plan. My theme is all about being predictable. What can we use as predictable factors? So interdental height of bone is huge. Can you change the interdental height of bone? The only way I know to do that is through ortho. So I'm not a big ortho person. I respect the orthodontist and I send it out. There's the odd case that we'll do in the office just from a costing point of view sometimes. And we actually did this case in our office here. I didn't do this restoration, but this weird restorations on these teeth. But we did. We took this endo-treated 1-4 and we super erupted it and watch the interdental height of bone that's on the distal. So on the distal of that 1-4, watch how far that came down by super erupting the tooth orthodontically. That's the only way that I know how to change where that interdental height of bone is. And what did that result in for us clinically? We sacrificed the teeth after we did our orthodontics and our grafting. This is the tooth pre-treatment. You can see that amalgam up the mesial surface of that molar. There's that endo-treated tooth that we've reduced and super erupted. And we end up with a pretty decent result. I mean, if you look at where that tissue level was on that molar, that amalgam was going way, way up to the zygoma almost. And now we got a pretty decent predictable result. So again, is that predictable? It is. I would tell that patient from the beginning looking at that case, you got so much vertical bone loss there, you're never gonna have perfect papillas between the teeth. But I think we got it down to a pretty reasonable level. We did that with implementing some orthodontic work prior to extracting the teeth. So for papillas, it's all about interdental height of bone. That's your main determining factor. For the zenith, we're going to have to look at where the crestal bone is. This is a pretty comprehensive case. This is a colleague. This is a dentist who came to me who I knew from our days in school, who had an implant placed by another colleague, and the implant was placed to buccal. The zirconium abutment fractured and it was non-retrievable, and they tried to retrieve it but damaged the connection on the implant. And so we decided to take the tooth out. So when we look at this case, we have to start predictably identifying factors that are going to result in this to be what kind of outcome are we going to get from this treatment. Currently, the papillas are actually in a pretty decent position. So I'm going to look at the x-ray. I'm going to check where is the interdental height of bone. The zenith I know is going to be a problem here because there's going to be a high position for the implant relative to where it should be, and it's too buccal, and there's no soft tissue volume. So I'm going to do this case in stages, and I'm going to have a plan to explant the implant and try and reconstruct what I can reconstruct. So there's the radiographs. We're looking at the interdental height of bone. So now we said on average the papilla would be 4.5 millimeters. I'm going to say that from this point of bone to this contact is more than 4.5 millimeters. Well, how can that be? That can only be if he's got a bit of a pocket here. So he also has a little bit of perio. So I measure the interdental height of bone off the x-ray, but I also pick up a perio probe and I go around the adjacent teeth to see if there's a pocket. So he might have a nice aesthetic look, but it's got a bit of perio. If you fix his perio, it's going to compromise his aesthetics. So you have to pick which one do you want. Do you want to fix the perio or do you want to preserve the aesthetics? We wanted to preserve the aesthetics. So we modified our incision design. I'm not going to go into that. Azim did a great job talking about all that. But we modified our incision design to preserve the papillas that we already had. We have to expose the implant. We have to explant the implant as atraumatically as possible. That was done with a piezo. And then once the implant is removed, we need to reconstruct the deficiency that we have. So we did a little bit of bone grafting, a little bit of perioderm grafting. We reconstructed the ridge to the best of our abilities. And this is the re-entry at, I think, 6 months later. And when we re-enter, we got nice ridge width, but we still have a little bit of a dip in the crest of the bone. But again, that's my biggest challenge, is getting that vertical level to come down any further. But from that first result, I think we have a pretty decent result. We have good ridge width. And now we're going to go ahead and place the implant in the right spatial position. We want it coming through the cingulum. We want good ample buccal bone. We want to let that facial flap come towards the implant so that we can actually reshape it with the final restoration. I don't have a great final photo because he went back to the original colleague who did the first implant to have the crown done. And so he sent me this little selfie and that's all I have. But all I care from this picture is look where my papillas are and look where my zenith is considering where we started. And I think that's a pretty good outcome. And again, that all comes down to identifying our parameters right from the beginning. So there's our pre-treatment and there's our post-treatment implant. Again, talking zenith and looking at papillas. So let's look at the two parameters we've talked about so far. Interdental height of bone to predict papillas, facial crestal height as far as predicting zenith. You should be able to look at this case and say, this is a problem with the zenith. You should be able to look at this case and say, is this or isn't this a problem with papillas? You don't know that. What do you need to do? What do you need to know that? You need to see the radiograph. So when we look at the radiograph, we want to look at where the height of bone is because we have to advise the patient that when I do surgery here, I run the risk of losing your papillas. So we look at the radiograph and you can see that the height of bone that's on the distal of that lateral is not in a good position. So I already know when I sacrifice this tooth and I improve the periodontal situation of this area that we're going to lose papilla in that spot. So this is after we extracted the tooth, we did a socket preservation on it, we went back in, we did a second round of grafting, and this is after the second round of grafting. But look here, we've lost the papilla. Predictable. It's predictable because what determines that papilla, again, is the interdental height of bone. New implant, its shoulder is pretty apical, so we expect to see a longer crown. And now that's the final result of the crown, and we're going to criticize the ceramics. So we're not done. That was the first phase of the crown, and then he went away on vacation, and he's coming back to have the ceramic work done. But the point of the slide is to show you that, look, all my cases don't turn out great. That's not me, though. That's lab. And so now I just got to get the lab to get this to look like a nicer crown. But I predicted the fact that the papilla was going to shrink on us because we looked at where our starting point was with his height of bone. And in my zenith, I think ended up in a pretty nice position. And that was only because we did some reconstruction first and made sure that the implant was pushed where? As palatal as possible to let this facial tissue come down towards the palatal. Starting point, predictable. Yeah, look at the height of bone where it is on the radiograph. And then we end up with a fairly decent result considering how dramatic that case was. So if we understand the fact that we're going to lose papillas and we're going to lose our symmetry of zeniths by losing tissue, really what's the best opportunity to preserve all that and maximize our final aesthetic result? It really has been shown that if we do immediate extraction and implant placement and immediate crown, that's our best opportunity to preserve our tissues, if appropriate, to get the nicest aesthetic result. So that becomes my go-to. So let's look at cases where we extract teeth, place implants, and do the temporary restoration same day. Difficult case, very pretty lady, friend of mine. She has a high smile line. She's got really nice teeth. We've already done extraction here, and she had a sinus lift here. So we've lost papilla on the distal of the 4 a little bit, but she's going to lose the cuspid. She's suffering external resorption. She's got external resorption on the 6, which she lost. She's got external resorption on the cuspid. She's got it on the 2-6 as well. So we're going to extract it and do a same-day implant and crown. And this is the result that we end up with after it's been restored. But if you watch that transition, there really was a very minor loss of papilla here, which subsequently has actually grown back in, but the zenith ended up in a nice position. We lost a little papilla here, but that's because there's been 2 or 3 surgeries in that area already. Look at the position of the implant, though. The shoulder is going to be, again, 3 to 4 millimeters from the CEJ of the final restoration. The interdental heights of bone are fantastic. That's what determined the papilla. And we've got our implant in a nice spatial relation buccolingually so that we have that nice zenith. Look at this case. If you take this tooth out and you see something like this, what do I care about? I don't care about this big lesion here. This is where this big endo lesion was draining. We curetted it all out. I didn't do as nice of a job as Azim does cleaning the bone, but that's how I do it. And so what am I looking at? I'm looking at my interdental height of bone, which is going to determine my papillas. And I'm looking at my crestal bone and a height and for my zenith. Is that going to give me a nice result? I look at that bone and I say yes. So this case, I'm happy to go ahead. Because of this bridge of bone compared to the last case I showed you, I'm happier in my hands placing the implant today. So I'm going to place the implant, make sure it's in a good position, buccolingually, emerging through the cingulum. I want the shoulder to be 3 to 4 millimeters from the CJ of the proposed crown. And I want to be right smack in the middle of the tooth mesial distally. I'm going to graft it. I'm going to let the graft heal. There's the implant again. Can you appreciate the fact that that buccal tissue is going to come way over to this implant? It's going to give me a surplus of tissue, which is going to usually result in almost too good of a soft tissue emergence profile. Temporary crown. Final result of the temporary crown. Look at where the zenith is. So the papillas are looking pretty good, and the zenith is actually almost too good. There's the temporary crown, there's the abutment, and then there's the final crown in place. Now, if I didn't like the fact that this zenith was too coronal, I can start to shape it with the crown contour, and I'm going to show you that in a moment. So there's our initial, there's our final, and again, the predictability factors have to do with the interdental height of bone and the crestal bone on the facial. Now, when you have multiple missing teeth, where we're advancing along from the single to the multiple missing teeth, it's hard to fill in those blanks. You don't know where the interdental height of bone is for all these teeth that are missing. You don't know where your buccolingual emergence profiles are going to be. This is the puzzle where you're all confused. So you have to fill in the blanks. You have to take your photos, you have to take your study models, and you have to fill in the blanks. Get the patient's denture. I know now by looking at this, if she likes this final result, all that pink is either going to be porcelain, or it's going to be an open embrasure, or it's going to be a longer contact point on the crown. Those are my choices. And on the upper left, I can start to see that the prosthetic starts to come out towards the buccal a little bit. So it might be a little bit of a ridge lap in prosthetics. So this is your diagnosis. Photos, study models, fill in the blank, show it to the patient, you learn from it, and then you know what the final result's going to look like before you start placing your implants. So that's predictable that I'm going to get a result like this. There's a bit of a ridge lap on the left on the second quadrant. I've got long contact points. I don't have open, she didn't want open embrasures, and she didn't want pink porcelain in this area. So it translates to a long contact. It's pretty straightforward. These are just variations of the same thing. These are lab prosthetic compromises for deficiencies that I couldn't fix. I don't know if anybody else could have, but I couldn't fix. And are these perfect aesthetic results? No. And again, you might see some really nice ceramic work out there. Our ceramists are quite incredible. I mean, they're artists, and they're all different. So with multiple missing teeth, we have to make a decision about where we're actually going to place our implants. And so now we need to understand some parameters about placing implants adjacent to each other. So when we place implants adjacent to each other, by default, we're going to end up with a smaller papilla. That's just the way it is. So between two implants, you're not going to get 4.5 to 5 millimeter papillas. You're going to get 3 to 4 millimeter papillas. So you got to be a little careful placing implants next to each other in the aesthetic zone. So sometimes in the aesthetic zone, I'll consider a cantilevered prosthetic because I can create a nicer papilla with a pontic than I can between two implants. So let me show that to you. This is a young girl who was in a snowboarding accident in Whistler. She came, well, actually it was her boyfriend's fault. They got off the lift and his snowboard came up and smacked her in the face and knocked her teeth out and took part of the anterior maxilla out. So what I want you to be able to look at is from the photo alone, if you look at where the papilla on between the 1.1 and 1.2 is and extrapolate a line coming across, and we draw that line across, look how big that defect is vertically between where the 2.1 and 2.2 are going to be. So we have a problem with the zenith issue in the sense that the crest of the bone is really high, and we're not going to have a good interdental height of bone between these two teeth. So I, in my hands, need to reconstruct this ridge before I do implants. She had a consult with another dentist in the city who was proposed placing 2 implants with same-day crowns on this lady. If you did that, you know where your zenith is going to end up. It's going to end up way up here and way up here. So I don't know how that was a fair proposition. Your prosthetic tells you a lot. So if you look at her prosthetic and here's her flipper, whatever the pink is, that's tissue that's missing. So if that tissue is missing, it's not going to be there if you place the implants in today. So look at your flipper, analyze the thickness of the flange, and look at the amount of vertical pink that there's there, because that's what's missing and that's what you need to surgically reconstruct. And again, that comes down to the understanding as a restorative doctor of what can be accomplished surgically and what can't be. And you need to engage with your surgeons if you're not doing your implants to talk to them about what their predictability factor is for different types of augmentations. So this is what a defect looks like. We've got a buccal lingual defect. And we also have a vertical defect. So we start to reconstruct it. So this is how she presented. And after our first round of reconstruction, this is how we ended up. And then I did a second round of reconstruction. But coming again to where we want that papilla to be is that if I place 2 implants and I told you implant to implant gives me 3 to 4 millimeters of papilla, am I going to get a papilla in between here? Absolutely not. It's just too far. So you're not going to get a perfect papilla here. And she had to be told that right from the get-go. She was told she will never, in my hands, she will never have a perfect result. So we've got good buccal lingual augmentation of the bone, but again, this area here, I can't make that part come down any further. So if I can't make that part come down any further, what else can I do? I can try and thicken the soft tissue. And again, Steve mentioned that in his lecture when he started talking about the vertical measurement. If I thicken the soft tissue, then I can create a more of an artificial thick papilla. And so that's what I did. I'm not a huge soft tissue grafter. I've got some limited abilities with it, but I did some augmentation and I thickened the soft tissue as well. We placed the implant in a nice spatial relation with lots of buccal lingual bone. Subtle detail, you'll see that I took a bit of the palatal tissue and I rolled it over to the facial to try and thicken the tissue a little bit further. And then we place an abutment and we get some temporary crowns. So it's a cantilever pontic and a temporary crown. We start to try and sculpt our soft tissue and see what we're going to get before we actually order our final prosthetic. So I can start to tell her, it's like, you know, you wear this for a couple months, we'll take a look at it, we'll look at your soft tissue profile, but I know here I'm already getting a long contact. And that was predictable from the beginning because of my understanding of vertical height from bone to contact point. So now I look at that and say, okay, am I planning on placing 2 implants here? If I place 2 implants here, I'm gonna have an even bigger problem with the embrasure. So that's why we placed the single. So now I think this actually turned out fairly nice. I think if the lab spends some more time on the case with the pink, we can get a nicer result. But in general, I think this actually turned out fairly decent. She comes from a distance, so this was the day we put this in. A small detail, and again, the more people will do of these things, and people that are experienced implant dentists on here may start to pick up on some subtle things. One thing I look at in patients now, because I learned from one case, which I think you'll see a little later on, I'm trying to get through, is pigmentation in soft tissue. So when you have patients of ethnicity and you see pigmentation in soft tissue, you have to watch that when it starts getting around your restorations and how you manipulate flaps. But that's how she looks now. So you can see the pigmentation, how that changes the appearance here versus over there. So how I handle flaps and when I slide flaps and move them coronally to cover grafting, you got to be a little careful with that. Here's what it looks like if you put two implants together. So implant and implant as opposed to implant with a cantilever. My implant to implant, I'm not going to get a great papilla. So I'm less inclined to do that in the aesthetic zone. So we place our implant, we have, we're going to do our crown. And when we do our crown, we can actually change the appearance of the soft tissue with the contour of the crown itself. If the crown is over contoured, it'll start to push the tissue away and move it more apically. How am I doing for time?
You're doing great, Steve.
Everybody okay? Nobody's falling out yet? Is that what I do? I watch these participant numbers and when they start dropping, I start going faster?
Yeah, I'll give you a heads up if it does.
Okay, thanks. So let's look at this case here. This is a patient who came in. She had a history of external resorption on that 1-1. And endodontist did a beautiful MTA repair on it. But at the end of the day, you should be able to look at this case and say, there's a problem with the zenith. There's good interdental height of bone. There's good papillas. So I got to fix the zenith, but I'm okay with my papillas. But I got to fix the zenith. So to me, that's not a same-day implant. That's going to be a staged approach. I'm going to take the tooth out. I'm going to do a socket preservation, and then I get this. Now I'm going to start reconstructing things. I place my implant, and look what happens. I put it in the right spatial relation. I move it to the palatal. That makes all this tissue come down. So now that's what I was trying to explain when I showed the implant towards the palatal. The facial tissue will roll over towards the palatal. Now you have a surplus. So now I've got the reverse problem. She started out with a zenith too high. Now I have a zenith that's too low. But now I can use my prosthetic to shape that tissue and get it in the right position. Now here as for the restorative doctors in-house here, you take your impression, you send it to the lab and you ask them to make you an abutment in the crown. Now this is what they give you. They give you a piddly little abutment with no emergence development. Now if you look at this abutment, you can already tell that it's not going to change where the zenith is. It's not going to, how am I going to have an emergence toward the mesial coming over to the 2-1? It's not going to happen. It's going to give me an ugly result like that. So it's your job to understand what the lab can accomplish so that you can actually prescribe an order and say, this is not appropriate. You didn't design this properly because you need to reshape those tissues appropriately. So you have to guide them and tell them what you want. I want that abutment to be wider mesial distally, and I want it also to be moving the tissues apically. That's why you see it blanching. Now, I look at that and I say, that's still not enough because look at the crown. The zenith still isn't in the right position. So we say, do it again. So he takes the second abutment and I ask him to make it wider again. And I ask him to develop the emergence on the gingival a little further. That's the difference in the abutments. Look at the gingival contour of the crown. It's over contoured. That's going to put pressure on the tissue on the facial, and that's going to move it apically. So your restoration can change the shape of the tissue. So you got surgical people that need to create the tissue for you, and then you got restorative people that need to shape the tissue appropriately. So interdental height of bone is going to get my papillas, but the zenith is going to be dictated by the crest of the bone and the shape of the crown. That's what we started with, and that's how we ended up. I think pretty decent result. One more, 2-1 is going to be extracted. It has a history of resorption. It's got external resorption on the palatal. You can see that here. I didn't think we were going to be doing a same-day immediate implant because the CT scan suggested there was no buccal plate there. When we extracted the tooth, there actually was a fairly decent buccal plate. Put the implant in the right position, let it integrate. Everything was good. I take the impression, I order the crown. This is what the lab sends me. I try the abutment on, I try the crown on. The zenith is too high. So if the zenith is too high, that means the gingival third of that crown and abutment is too contoured. So I take a high speed and I reshape that abutment and I made him a temporary crown. And that's my temporary crown. It's not the nicest temporary crown, but the point is to show you that by changing the shape of the abutment and the crown, that's the same case. The tissue looks completely different. So you got to appreciate restorative docs. When you get your lab work back, you need to understand how it's done, if it's done properly, and can it be changed to accomplish the result that you want to accomplish. Don't just put it in the patient's mouth. So decent result. Is it symmetrical? It's not symmetrical. Look at the shape of the distal of the zenith there. So that's a mirror image of the line on the 1-1. And you can see that this part of the crown and the abutment needs to be reshaped to make that symmetrical. So we start with that, we end up with that. And believe it or not, he's not happy with it. We're doing the crown again. So Diagnosis-wise, predictability for the zenith. I showed you this case already. This is a unique situation. Bank this for people that do younger kids that have congenitally missing laterals. These are one of the few cases that will usually have too much of bone, and the crest of bone may be too coronal. So these are cases where you may have to actually do some reduction of bone prior to placing the implants. How do you diagnose it? Photos, study models, have the lab wax up the tooth and make an Essex. So here's a case, photos, we did study models, we had a wax up done of an ideal zenith on this case, and then we made an Essex from it. So at the time of surgery, when we flap the patient, we can measure from the crest of the bone to the zenith, and we need 3 millimeters. So we can see that we need some reduction here. If I place the implant on that patient today, the crown would be very stubby. So we do a little bit of reduction. Now I've got from the head of the implant to the zenith, my 3 millimeters that I need for my spacing. So very important, bank that one for your congenitally missing lateral cases. That ends up with a zenith in a nicer position. That's just a temporary crown because if you look at all of this patient's teeth, they're not nice. I did a little bonding here because he had a peg lateral quite some time ago, but he's gonna have veneers done on the 1, 1, and the 2, 1 because they're not symmetrical. But look at the zenith. The zenith is in a better position because the implant shoulder was placed at the right spot. So if we take a case like this and we start going through treatment planning and incorporate everything we talked about so far, zenith and interdental heights of bone, this is a hygienist who's seeing a periodontist for regular maintenance and is suffering over eruption of teeth and perio, and she's got lots of issues. And she's not happy. You can see that the embrasures are opening. So you know before you even look at her radiographs, she's got bone loss. You know that. This side is worse. Look at the embrasures. We got a zenith problem on this cuspid. We got a zenith problem on this lateral. So the left side, the 2-2 and 2-3, is going to be more difficult when she loses those teeth to get those zeniths in the right position without doing some kind of reconstruction and some kind of augmentation. When you look at her radiographs, look at the cuspid. You can see that the interdental heights of bone are not in good positions. So in a perfect world, I would want this lady to actually have some orthodontic work to extrude those teeth and bring that bone down as much as possible. I don't think it's practical. And I'm not sure if ortho is an issue with respect to her residual periodontal issue on the remaining teeth. So she may have to accept a compromised result right from the beginning, but we're gonna reconstruct it as best as we can in stages. So I would extract the teeth, do socket preservation, and then look at what we get from that, and then do whatever kind of augmentation that we have to do to get her to a final result. But you can kind of see where we've got open embrasures and where we've got loss of bone. It's all the interdental height of bone dictates what the papillas are going to look like. So what we did for her at the beginning was we just did a little resin buildups on her laterals just to make them look nice for now while we come up with the treatment plan. And then now it's going to be a matter of which teeth we're going to be sacrificing, where we stage our implants, where we place them. Do we stagger them? Do we put them adjacent to each other? No, we don't in the aesthetic zone. But we have to go through our proper diagnosis. So that's single teeth and then multiple missing teeth. And then now we're going to talk about full arch cases. And I think I'm an hour in, so I should be okay. And I haven't lost too many. So for full arch cases, things are no different. Photo study models, Panorex, complete denture setup, because again, we're working from the final result backwards. Figure out what the patient wants to see. You got to show them what the teeth are going to look like before you start. Cone beam, yes or no, and decide surgical guide, yes or no. If you're going to send them for a cone beam, you send them with that denture setup, and you get a dual scan done. So you get your photographs, you got your study models, and you get your denture set up. So whether you're going to be a digital dentist or if you're going to go old school, the process is the same. I still go through these steps every single time. Old school, I could use the denture setup and I could flap the patient and I could place the implants using the denture as my guide in combination with my understanding of the bone to see where the implants belong. So that would be my old way of doing it. And actually, it's the way I do majority of them, quite frankly. Or you could do the digital approach with a fully guided case. To accomplish this step, to fabricate this guide, you still need those first steps. You need the photos, you need the study models, you need the full denture setup. And you end up with a pretty nice result. But what you end up with is you end up merging your denture setup, which is your STL file, with your cone beam data in order to do a proper comprehensive treatment planning. And I'm not going to cover all that. Jeff might be talking about that as part of his lecture. I'm not sure. But for edentulous cases, you want to get what's called a dual scan. So what you're seeing on the image here is those little balls are little radiographic beads that were placed on that denture setup at the time of scanning so that we could merge the two data sets together and do a proper treatment plan. So proper treatment planning means not just looking at a bone and firing 4 implants into it that work for the bone. It means putting 4 implants in the bone that work for the bone and work for the prosthetic that you're trying to accomplish. Again, going back to that case that the doctor sent me, you can see here that where her patient's prosthetic belongs and where the patient wants, look how facial that is to where that buccal anterior maxilla is. It's too far facial. If the implants were placed there with the intention of doing a fixed prosthetic, you can't, because you'd have the porcelain and metal framework half an inch in front of where the implants are. So this is a case that's suitable for an overdenture, but it's not a case that's suitable for a bridge. And that diagnostic happens on the software. So again, it's all part of the treatment planning. This is poor treatment planning. I didn't do this case, but this is somebody who fired 4 implants in after they extracted the teeth without any kind of understanding of what, and I'm not going to say, no understanding of what was going to happen. I guarantee you, and I know from listening to the patient, they had the teeth removed with no flap and the implants were placed in through the sockets. I would never do that in the anterior mandible like that, because if you flap enough people, you know what that bone looks like. There's been no respect for interarch clearance. How are you going to do an overdenture on top of that and have enough room? Look at the tooth in the posterior. There's not enough room for the prosthetics, and the implants aren't in the right spatial position. This is what the anterior mandible looks like once you flap it. Look how thin that bone is. That cribriform plate of bone typically resorbs after teeth are removed. So that's not an appropriate place to place an implant in unless it's grafted. And if it's for a single tooth restoration, that's fine. But for an overdenture, we need to subtract that. We need to reduce it. We need to make interarch clearance for our prosthetics, and we need to get the implants into a more robust, healthy, substantial section of bone. The other part of the problem with the mandible is it has a flare to it like the maxilla does. And if you place your implants into the anterior mandible here, starting at this crest, they're going to flare facially. Now, for a single tooth restoration, that's fine because your abutment will correct that and then your crown will slide on top of the abutment. But for an overdenture case, that's not appropriate. So we need to reduce that bone down for interarch clearance and for proper spatial position of the implants. Going back to the theme of records, this is a patient who, again, just like the other one I showed you, has external resorption on almost every single tooth. We sent her for cone beam. She presented to me in this state where she's already lost several teeth from external resorption. So we sent her for full arch cone beam, upper and lower, and all the teeth, and every tooth on the lower arch has pretty moderate to advanced external resorption. So the plan was to extract the teeth and place 4 implants for an overdenture. Well, even without you people seeing this patient, just by looking at this photo and then this photo, more importantly, you should appreciate that she's overclosed and I have a real problem with interarch clearance. So I need to incorporate some bone reduction to accommodate my future prosthetic space requirements. How do I figure that out? Photos, study models, do your setup, and figure out your measurements. Once you figure out your measurements, then you know what you need to do. She has tori, so I'm going to consider removing those tori at the time of implant placement. So we flap her. There's the tori. We do our ridge reduction. You can see how we've done our reduction for our calculated space requirements. I'm not going to cover that today. I just want you to understand the concept. And we remove our tori. So you do it all. You don't just treat the implants. You don't just take the teeth out. You treat the problem. So by looking at the photos and doing the proper diagnosis, you can come up with an action plan, as Azim mentioned with respect to the whole surgical procedure. You place your implants, you suture it up, you let it go. Full clearance. From the photos alone, you should be able to look at this. When this patient loses these teeth, if I place implants for the purpose of a bridge, that's fine. I can make him look like he did before. But if I want to place a denture, this transition zone of where his lip is and where his smile line is, if I don't give enough clearance on this case, then I'm going to have a problem with the prosthetic transitioning off of the implants. So it's going to need some reduction. So I don't just take the teeth out and fire the implants in the holes. I flap it and I have to reduce it. I have to give space for my ultimate prosthetic and to make that transition zone hide underneath the lip. Reduce the ridge, place the implants, There's some grafting. I'm just going to go through these pretty quickly. Same thing on the lower arch. Take the teeth out. You got to reduce the ridge. Azim showed some nice slides of the mental nerve as well. Reduce the ridge, take your measurements, get the good flat solid bone, place your implants. And then we end up with him going home with a temporary prosthetic where you can see the transition zone is nice and tucked in underneath the lip. And we did that only because we were able to remove the bone to a level that allows that transition. So in summary, I think this is my final slide. These are the things I want you to take home from this. Your interdental height of bone will affect your papilla, bottom line. So for your single teeth cases, you want to look at the patient clinically, you want to look at your radiographs, you want to see where your bone is on the adjacent teeth. And you saw in that one case I showed you of the dentist that we modified our flap design so that we didn't improve his perio and then therefore lose his papilla. But we assess it with both our perio measurements of the adjacent teeth and with the radiograph, and that is what's going to dictate papillas or not. For multiple missing teeth, so for bridges, your interdental height of bone between two implants, you're not going to get a huge papilla between those two implants. So in the aesthetic zone, consider intermittent implants as opposed to adjacent implants. So that'll affect your treatment planning. The crestal height of bone on the facial is what's going to have a big impact on the zenith, and the spatial positioning of the implant is going to affect the zenith. If you place the implant towards the palatal, you're getting a free connective tissue graft. The connective tissue is going to roll over towards the palatal, and then you can just fix it with your restoration contour. So the contour of the abutment and the crown can then correct it. That's an easier problem to have. It's more difficult to ask someone to surgically graft up to an implant and get good tissue. I'm not a periodontist, and I'd love to know the input from the periodontist on the forum, but I think grafting up to implants is probably less predictable than grafting up against teeth. So if you've got a surplus of tissue and you can just correct it with a contour of the crown, I'd take that all day long. So for fixed restorations, think about the concept of tissue preservation. So if I'm doing a single crown, you're obviously thinking about tissue preservation. If I'm doing a bridge work on a patient, I want augmentation. I want as much tissue as possible. I don't want little amounts of tissue. If I'm thinking about dentures though, I'm thinking about removing tissue, not soft tissue, but bone, because I need the interarch clearance. So fixed bridges, you want the tissue for the aesthetics. For dentures, as I said in the first slide, the patient's committed to pink prosthetics. They know they're going to have acrylic. You're going to think about subtracting tissue so that you've got the right spatial dimensions and clearances, interarch clearances. So you've got room for the denture tooth, the flange, the bar, the conus abutment, whatever it is you're doing, you need the space. And if something about the implant position is not ideal, then we deviate. Now we're doing corrective measures. So now we're trying to make things look nice with our bag of tricks, with our ceramic work. So, everything, when you look at an implant catalog book, usually all the pages that are in there are surplus for adjunctive things that you need to utilize to fix problems. If you don't create a problem to begin with, you're going to use a standard routine number of products. You're going to use the same abutment every time. You're going to use the same kind of crown design every time, assuming the implant's in the same ideal position. So it's all about having the plan so that you end up with a predictable outcome and you have the implant placed in the right spot to begin with. So that slide at the end, I think, is kind of helpful for if you're surgical, then you can kind of know to look at certain things. If you're restorative, you know to look at certain things and kind of help you out with your treatment planning. And I'd be curious, so two things I'd be curious about is if there's periodontists on the forum, that comment I made about the grafting against an implant and whether or not that's something that they think is predictable, and would they rather do it in advance of the implant being there, or do they get good results after implants are already placed? And the second thing is, how many of the specialists that are in-house follow up with their implants after the restorative doc has restored them to look at some of these parameters? And I know Kayvon mentioned his photography, and I think he probably does do that, because if he does pre-treatment photography of his cases, it'd be nice to have a photograph of those cases after they've been restored, so you can actually look at them and analyze them to say, hey, how come we ended up with this as being a great result? and versus this one didn't, and what was the parameter that defined it. And I think if you look at those cases, you always come back to these things that I've kind of highlighted here. So I think that's it. Everybody still there?
Yeah, we're all here.
Okay.
Awesome. Perfect.
Any comments or questions, or what do you want me to do?
Absolutely. So you can just stop screen sharing, and then we can move on to the next. Awesome.
All right.
Thank you so much for that. That was absolutely incredible. I was fully engaged the whole time. It was great.
It was very quiet.
Yeah, I know. It's kind of disconcerting, right? You make a joke and you can't hear anyone laughing.
It's kind of like,
You're laughing, don't worry.
yeah. No, I hope that was helpful, and I think it's like I say. I think that the lectures that came in advance of me were so good, and I think having listened to them myself, I think Steve's lecture and Azim's lecture, Kayvon's lecture was just over my head. I mean, I don't do orthodontic surgery, but both of those lectures I think were phenomenal. And one of the things that Azim said as well that I took away from it that I thought was very, very I can relate to is paying all this money to go to courses and sometimes only extracting one thing from it. So he made the comment about I paid $5,000 to go to a course, and then I learned this concept of suturing so that I can coronally advance my flap. I take the needle from the flap to the recipient site from an apical coronal point of view to drag it down. And that's kind of a testimony to the fact that you're doing some pretty cool things, because if you go to a course and you spend 3 days there but only extract one thing from it, it's very reassuring that what you're doing is consistent with the way things should be done. So I respect those kind of little comments. And so it kind of tells you where people are and what kind of experience that they have. And it's a huge amount of knowledge base that you've got on your forum. So congrats to you for having this as a pretty informative platform for all of our colleagues.
Awesome. Thank you. And that was absolutely incredible. As I mentioned to you, Steve, is that you brought, and Jeff Sumner said something that also hit home as well, to say, you know what, you were one of his mentors when it comes to placing implants. And a lot of the things that you've said, it's very true and practical on a day-to-day basis, right? And I wish I saw this when I first started placing implants, because a lot of the mistakes that you talked about, unfortunately, were not discussed when I was learning how to place implants. And obviously hindsight is 20/20, but those are some incredible pearls that you shared with us. So thank you so much.
Yeah, it's a tough hat to wear when as GPs. I mean, if you're a surgeon or a perio and you do this like routinely day in and day out, and you go from implant to implant to implant to implant, you get into a real groove. But when we go from an implant to an endo to a pedo, I try not to do that. You gotta be able to focus. And again, this is where I kind of really appreciate some of these experience levels, because Azim said that as well yesterday, where it was like, you can't go do hygiene checks when you're doing this. You got to sit down, you got to focus, because you got to be focused. You got to be in the groove, and you got to have those hats on so that you understand what's going on and not make these little mistakes.
And I think just to add would be that, it's very powerful having people like yourself who are in the teaching industry as a GP, really, truly, being there to help share, right? I think that's a powerful thing to have, and to really be open and share through your club is just amazing. So I think it's, thanks for the lecture, was amazing.
Yeah, thanks. And I said that to Shan this morning too about yesterday, kind of respecting our colleagues and with Kayvon on what they do, because we think we know what our colleagues do on a specialist level, and sometimes we maybe take a little offense to them being critical of what we do, because we think what we do is pretty good. But then, I look at that one slide he showed of the patient on the table with their having external drainage done, and you realize, we're doing some things to people that have some pretty big potential consequences. So you got to respect it for what it is. And people shouldn't be dabbling and delving into things unless they've got a real good confidence level with it and understanding of it. That's not to be said that you're not going to have to pass off things to get fixed sometimes, because some things will be outside of your realm. But don't be offended by some of our specialist colleagues being critical of us doing it, because look at some of the things that they have to deal with and things that they see. Now, when you know what you do, you feel like you're not part of that, and that's fair. But as someone else said prior to the lecture, you know, there's a bunch of our colleagues out there that maybe aren't at the same level and dealing with cases in the same way. So, you know, hats off to all of our colleagues and what they do. And we kind of all have to, I don't want to say know our place, but you got to do it if you're doing it right. You can't dabble. I think implant dentistry is just not a dabbling thing. You're either in or you're not.
Absolutely. And I think to add to that too, Steve, is, you know, if you have colleagues that genuinely are looking after, or, you know, they genuinely care about your overall interest and well-being, you know, having them involved with the conversation and having them, you know, participate in it directly or indirectly, or if you're struggling with something and you share that with them, it's in their best interest to help you out as well. Right. So, you know, if you go ahead and you run into a complication or anything like that, and if you have that good relationship with an oral surgeon, a periodontist, or whatever it is, there's never going to be any type of animosity or, oh, Steve, you shouldn't be doing this or shouldn't be doing that. It's okay. Look, I'm here to help you because I know that you're trying to push the limits within what it is that you're trying to do. And I'm here for you. Right. And that's how these kind of relationships work. In my opinion, you know, working with specialists has been an absolutely incredible, you know, privilege in so many different ways, but making sure that these individuals want to see you succeed and want to push you as well in whatever it is that you're trying to pursue.
Yeah, well said.
So we'll start with a couple of housekeeping items. I know Azim just might have jumped off. He might be preparing for his upcoming lecture. There he is. So go ahead and put the link to Azim's talk. So if you guys have not already, please feel free to go ahead and register right away. I know it's getting very close to capacity if it's not there already, but register. I know there's a lot of CEs happening, but this one starts in about an hour and a half. How are you feeling about this, Azim? Are you excited for this upcoming talk? Oh, you're muted.
Yeah, no, I just learned a ton from you know, Dr. Diana's lecture, so I'm just digesting some of that right now. No, I mean, as far as the sinus stuff, it's an amazing. I'm excited because this is a tool that I use every single day in my practice, and I think everybody should be comfortable working in the posterior maxillary area. So yeah, I'm excited, man. I'm pumped.
Absolutely, I'm looking.
I'm excited too. I'm going to start doing it.
Yeah.
I think you should. Absolutely.
The first orthodontist that's ever doing sinus lift, but I think it's pretty cool.
Listen, if endodontists can do implants, I think orthodontists can do sinus lifts.
You're right. I just don't have any anesthetic in my office. This is the problem.
A couple of other housekeeping items. Make sure you check out our YouTube channel at Dentistry Disrupted. A lot of these talks will be posted on that channel as well. So if you missed something, or if there's something that you want to go and check out again, or if you want to share this with a colleague, please feel free to visit us. Just type in Dentistry Disrupted on YouTube, and a bunch of really, really cool talks will show up. The other thing too, as we mentioned before, is we have our good friend Vic Jindal, who's going to be doing a very big talk this upcoming Monday. There's going to be two talks, one at 10 a.m., the other is at 2 p.m. I've put the link to those talks as well, so please make sure, as Manisha mentioned, to register early, as space is becoming more and more limited each day. And finally, for our upcoming talks, please feel free to visit www.dtacademy.ca/webinars in order to register for Dr. Queck's lecture tomorrow and Dr. Sumner's lecture on Tuesday. We're looking forward to both of those. So we're going to go ahead and get started with some questions. Go ahead, Manisha.
Okay, perfect. And just one last thing on the housekeeping. We just emailed out all the certificates for last week. And what we'll do is just email them out weekly. So you will receive this one by the end of this week, give or take.
Now, Manisha, while we're talking about that real quick, a couple of individuals have asked me that they've stated that the certificates that they received did not have their name specifically on it. Can you please elaborate on that? And in the event that is that okay for the RCDSO's kind of rules and regulations when it comes to?
It's totally fine. So you may have attended other lectures in the past where they'll just actually give you a blank one, and then you just write your name in. So the main thing is we have the list of all the people that have chimed in and written their name and email. So that's our verification that you attended the course. So if there's any question, then they can, if our CDS wants verification, we can provide that. So it's perfectly fine for you to write your name in there. And as long as you know you've written your name in the chat, you are good to go. And that is a completely valid certificate. This club has been running for many years, and this is how we've always done it. So no concerns at all.
Thank you, Manisha.
No problem. Okay, so first question from Azim himself. Are you using any soft tissue grafting in these cases?
No, I think Azim did mention that, this whole issue of the Achilles heel being sinus for some people and soft tissue for others, or both. So I'm very confident and comfortable with bone and sinus surgeries. And the one thing I've never had in my practice that I've been comfortable with has been soft tissue augmentation. So when I have cases that need a lot of soft tissue augmentation, unless it's something that I'm just going to do as an adjunct to something I'm already doing, I'll use perioderm or alloderm, but I don't do any palatal harvesting anymore. It's the one thing I need to work on. So no, I haven't done any kind of soft tissue augmentation on those cases, except for the one that I showed you of the dentist on that central incisor where I explanted the implant, because I just basically utilized the perioderm in conjunction with that flap. So it wasn't a procedure in and of itself. It was utilized in addition to what I was already doing. And the other one was that the girl who got snowboard to the face, same thing. I just sutured a piece of perioderm to the undersurface of the flap at the time of the bone augmentation. So yeah, I'm not a PRP, and I'm not a palatal soft tissue graft harvesting person.
I think what I loved about it was the simplicity of what you were doing and how you were manipulating the tissue to just get more soft tissue at the time of surgery. And I think sometimes people kind of overcomplicate. Do I have to put a CTG? Do I got to do all this stuff?
Right.
And then it just becomes a hot mess when it comes back to suturing things. So yeah, that's what I kind of got, which was great.
There's little thing. I mean, every time, like you said, when you go to courses, you pick up little tidbits. And I remember going to a course years ago, and he showed that little bit of manipulation of where your flap margin was. So you might have noticed a lot of the flaps were extended a little bit more towards the palatal, and you end up taking palatal tissue and dragging it to the facial and rolling it underneath. And so you denude it. You take the epithelial side of it off, and you can roll it underneath, and you can get some pretty good augmentation in some pretty creative ways. So I think we all have our tools in our toolbox. I don't think anybody can have all of them. Well, some people do, but I don't. Unless you do this day in and day out all the time, you can't master them all. So you find some things that work. So for me, even for augmentations, like a block graft has always worked incredibly well. So that's my go-to. Getting big augmentations with GBR hasn't really worked for me. So I always default to a block graft. But you go to lectures where guys will show huge augmentations with GBR, and good on them. So when you find what works for you, that becomes your technique.
Thank you.
The next question, Steve, is actually from myself. The main reason why is that I get this quite often, with regards to your P2P courses. Do you recommend a young dentist learning how to, who's getting into implantology, to learn how to restore implants or place them first?
Ouch. I have mixed feelings on that. I mean, I've been very grateful for all the young dentists that have come through my program, and I think I do a pretty respectful job of unleashing them on the world with a respect and an understanding for it. But like I said, I think implant dentistry is something that is very comprehensive, and either in all the way or you're not. And dabbling is something that I don't think you can do. And no disrespect to new grads, because I remember I was there once too, and we all have a lot of confidence when we graduate. But until you've experienced a lot of these hurdles personally, it would be very remiss, I think, to be firing in 100, 150 implants in, because they'll all work. Well, they won't all work, but the things will work for a period of time. But then in hindsight, once you learn other things in dentistry that could have made the cases better, until you have that knowledge base, I'm not sure if it's really what you should be starting with. So I think probably to answer that question is restorative for sure, because if you get implants placed, and you should be able to restore them, absolutely, and watch how those restorations behave and some of those consequences that we just talked about, the contours of the crown, how that affects the soft tissue, and that'll make you have a better appreciation for the surgical side. So I'm not trying to dissuade people from learning the surgical side, because you kind of need to know both, but it doesn't mean you'll be doing both right out of the gate. Is that a politically correct, neutral answer?
I think it's a great answer. And I couldn't agree with you more. I think understanding how to restore them and working with a good mentor that, you know, can help you through and walk you through even the surgical process for the first couple of times, so you see it and you understand the concept of it, and then go to place on your own is what I would recommend as well. And I think you hit home there.
Thanks.
Next question comes from Farah. For the single tooth with the large gingival and buccal defect and lateral wall of bone missing, how was it treated?
I don't know if I know which one that was. Single tooth with the large.
Farah, if you are on at the moment, if you want to unmute your mic and maybe you can clarify your question.
I believe this is the one with a large tooth, anterior tooth restoration that you were restoring. I could be incorrect though. So if
like the 2-1, the 2-1 and the 2-2?
Yeah, I think it was the 1-1.
The one
single tooth.
Yes, it's single tooth.
No, it could be. No, I don't think it's that one.
There was
you know what? Why don't we have her clarify the question in the chat and we can move on to the next one.
Okay, you got it. The next one is from our very own Jeff Sumner. He asks, after significant bone reduction, what do you do with the overabundance of tissue while still maintaining as much attached gingiva as possible?
That's a good question, actually. So, I mean, people have a tendency to want to approximate the margins of a flap together to make it look nice and tidy at the time of surgery. And you can only do that if you cut tissue away. Now, in the lower arch, usually my incision is such that I'm going through the middle of the crest and I'm splitting the keratinized tissue facial lingually. So I have equal amounts of lingual and facial soft tissue with the keratinized margin. So I don't take any of that away. So it looks like a disaster sometimes at the time of surgery, because when you reduce that amount of alveolar bone, it's big and bunched up and it looks like it's not going to heal nicely. It does. So I don't resect any of the soft tissue. I just suture it, and it's big and floppy and sitting on top of the bone. And when you see them after it heals up, it reapproximates quite nicely. Now in the maxilla, you can get a little creative, and Azim actually showed a case, I think, where he rolled the keratinized tissue from the palatal over to the facial and put a little hole through the healing cap on one of his cases. And you see what I mean? Like if you do enough of these cases, you'll pick up on those little things. But if you don't, you wouldn't have picked up on that necessarily. So on the maxilla, you can get involved with a variation of your flap design to get around that. But for the most part, in general, I don't resect it. I don't cut any keratinized tissue and discard it ever. Think about how much work our periodontists do to get keratinized tissue around a single tooth. So why would you be so casual to cut any away and discard it? I wouldn't.
Makes sense.
Okay. Eric Neves asks, what burr do you use for alveoloplasty flattening of the ridges?
So I use a burr from Salvin. It's a Mike Picos, P-I-K-O-S. He's an oral surgeon out of Florida. It's his bone contouring burr. It looks like a big acrylic round burr. And we use it on it's on a 1-to-1 straight handpiece that goes on your surgical motor.
Awesome, thank you. The next one is from Dr. Balbaki. She asks, thank you for the well-organized presentation. Bridges on implants with engaging or non-engaging abutments. What is the indication of each?
Oof. I think everyone's got their own feelings on that. I personally like engaging, so indexed abutments. So I like indexed abutments myself. And then if I'm doing a but that has to be, see the problem is if you're doing a bridge to a bridge on several implants, you have to have an intermediate abutment if it's going to be screw retained. If it's going to be screw retained on an Astra implant, you're going to have the multi-base abutment or the uni abutment. And then you screw to that. So the bridge is non-engaged to the abutment, but the abutment could be engaged to the implant. So there's an intermediate. You never screw a multi-unit restoration directly to the implants. Does that make sense?
Can
So
you
never
that a little bit more, Steve?
so you don't have a 3-unit bridge screwed to 2 implants directly, because there cannot be a common path of insertion. So you have to have an intermediate abutment between the implant and the restoration. The alternative to that is you could place 2 abutments and cement a bridge to those abutments, but you cannot screw directly to fixture with a multi-unit case. And now sometimes people would try and say, well, if I use non-engaging, I can do that, but that's not the workaround. So you cannot say, well, because I use non-engaging abutments, I can just screw that bridge directly to the fixtures. So yeah, sorry, I don't have a more of a.
Yeah, and I've seen actually some labs do that without even talking to the dentist about it. You know, just to provide 2 screw retained abutments on a bridge, but then they'll go ahead and disengage the connection from the abutment to the implant, right? And I think we can both agree. I think we can all agree to say that, you know, that's not really what the intention of the internal. That's not how an abutment is to be seated to onto the implant, and does that put a lot of stress on the prosthetic elsewhere?
Right, and interestingly enough, this just came to light to us, and I don't know if Elaine is still on here or not, but the Dentsply Sirona family, if you order directly from Atlantis will actually fabricate non-engaged bridges to implants to allow you to screw directly to the implants, which is totally off corporate as far as what they promote. They promote that you should have an intermediate abutment between the implant and the bridge. So when you're thinking bridges in general for multi-unit cases, you are either doing one of 2 things. You're putting in multiple abutments and you're cementing to those abutments. So now you've created a path of insertion at the abutment level, and the bridge cements to that. If you're going straight to, you can't go straight to the implant with the bridge. So if you want to screw it, you've got to add an intermediate abutment, the multi-base or the uni. And every other company has their same variation of those.
Now, you know, the next question I'm going to ask you here is that, and I'm sure some people are thinking about it, is that what about cement getting underneath the abutments and causing some long-term damage to the implant?
For sure, and I bet you the perio people on here hate me saying that about cementation. So you got to be, if you're going to get involved with cemented restorations, you got to have a very stringent protocol for how you do that. And that's where something like the Atlantis abutment becomes so useful, because you can really control those restorative margins. So depending on the design of the abutment, it's going to have a huge impact on your ability to control excess cement. So you have to have a cementation protocol. You have to have an understanding and respect for the fact that cement can get past your margins, and you have to control that. And one of the best ways to do it is to control your margin. And again, that's where the Atlantis abutment really comes into be a key player for my practice.
We have one more question from Dr. Mian Kwek. He asks, what is your experience with bridges spanning implants to natural teeth? If so, what parameters do you follow to decide to achieve long-term success?
I'm a GP, man. I'm not a prosthetist. That's a pretty sophisticated question. That's a pretty sophisticated question. That's a long talk, and I'm not gonna preach to understand that in its entirety. But I'm gonna say in my 23 years of doing implants, I've probably done 5 of those where I've utilized an implant to a natural tooth, and I've done that for reasons where, on average, it has to do with maybe me not being able to get multiple implants in the edentulous site. I can get one, and so basically, I look at the health of that tooth that I'm bridging up to. And so if it's a good, stable tooth, then I'll connect to it. My understanding of that has to do with, we all think that the tooth moves, the implant doesn't. So we got to worry about how those components behave. And if you have an implant system that has a poor abutment implant connection, then the strain on that implant abutment connection via the movement is what results in the micro movement and the micro gap opening and closing. And so for non-Morse taper conical connection design implants like Astra and like Ankylos, those implants typically don't behave very well when you splint them up to natural teeth. There's a lot of data on the ankylose platform that shows utilizing ankylose implants to natural teeth has some good longevity, and it has to do with that connection. So again, because of the movement of the bridge is the concern, and what is that going to have an impact on? It's going to have an impact on the tooth, or is it going to have an impact on the implant? On the implant side, that weak connection of a non-Morse taper, non-conical connection, I think is what suffers. So I wouldn't say it's my go-to, my default as far as my treatment plan goes. It's going to be a compromised last resort treatment.
And we wouldn't recommend this for anybody that is learning how to do implants, especially early on.
No, okay, again, because it's a go-to saving grace type of treatment for me, and so I wouldn't say that's where you start.
Absolutely. And I'm going to ask one more, even though we're not recommending this, I'm going to ask one more question with regards to this this subject. Is, do you screw retain your implant abutment crown, or do you go ahead and cement it?
So I screw.
So
So do I do a screwmentable, like a screwmentable?
Correct.
So I'll tell you. So I've defaulted to trying doing screwmentables now. So what I do is I get my abutment and my crown back from the lab. I try the abutment on. I try the crown on. So the reason why I do that at the beginning is to adjust my contacts. So if you were to cement your crown to your abutment as a unit and take it to the mouth and try and seat it, if you have a conical connection implant, your radiograph is not going to show you that it's absolutely seated. Mm-hmm. If you have a butt joint connection, abutment implant, then you can. But with this conical connection design of ankylose and Astra, you can't. So if the criticism of doing a screwmentable, I think from what I've understood from Prosto, was that if you take that crown and you try and seat it, but the contacts are too tight, you may get it torqued down, but it won't actually be fully engaged. And what will happen is a lot of those crowns will come back and they'll be loose. So now that they've loosened, what will happen is the adjacent teeth will have spread, and now you just retorque it and it's all good. But that won't happen in between implants. So if it's multiple implants in a row, they won't move. So I try the abutment on, I try the crown on. We're all restorative doctors. We know how to adjust crown contacts. I adjust my contacts. Once I've got them to the point that I know they're good, if they need to be adjusted, then I'll cement it extraorally and I'll screw it in as a unit.
Awesome. Perfect. Thank you.
All right. Good.
Awesome. Well, I think that concludes. Sorry, did you have anything more to say, Steve?
Nope, I'm good.
You're good? Okay, awesome. Well, I think that concludes our lecture and discussion for today. Well, actually for just now, we can tune back in at 3 o'clock for Azim Sheikh's talk as well, please. And we'll look forward to seeing you soon.
Awesome. Thank you so much for everything, Steve. And for those attending tomorrow, same password. We'll see you for Dr. Mian Kwek's lecture at 12 p.m. We look forward to seeing you then. Have a good day, everyone.
See you guys later.
See you. Bye, guys.